Well, hello everybody. Welcome back from the coffee break to this second panel session, Opportunity or Threat, How AI Could Change Work in Healthcare. My name's Tim Horton. I'm an Assistant Director at the Health Foundation and I'll be chairing the session today. We've heard a lot so far about some of the promise of AI and some of the exciting opportunities it offers. But of course, AI is also going to bring what Eric Topol calls a profound digital disruption in how healthcare is delivered and in the ways staff work. That was when he did his review for the NHS 5 years ago. And I would say, if anything, since then, with recent technological progress, our estimation of that disruptive potential has probably only increased further. So that's partly why we wanted to come together today and take a fresh look at these issues of how AI could change work in healthcare. And to do that, I'm delighted to be joined by a very illustrious panel. We have Susie Shelmerdine. Susie is an associate professor at the UCL Great Ormond Street Institute for Child Health and a consultant paediatric radiologist at Great Ormond Street Hospital. Avi Mehra. Avi is an associate partner and clinical safety officer for healthcare and life sciences at IBM. Erica Denton, a consultant radiologist and interim National Medical Director for Transformation at NHS England, and Hatim Abdulhussain, Chief Executive of Health Innovation Kent Surrey Sussex, part of the NHS Health Innovation Network, as well as being a practicing GP. So thank you so much for joining us today. If you'll allow me a minute just before we launch into our discussion. I realised I've done this, I haven't got the clicker. Is the clicker there? Thanks, Susie. I knew I'd forgotten something. Technology. So if you'll allow me just one moment, I wanted to say one other reason why holding this discussion today was important for us, and that's because at the Health Foundation, supporting health and care workers to improve healthcare, including with technology and AI, is very close to our heart. This slide's just got a smattering of the work we've been involved in the last few years. You've got our innovation programs over there. Listen, Learn and Improve. It's a really interesting project at Imperial NHS Trust and Imperial College using natural language processing to analyse patient feedback and help staff respond to patient views. We've been supporting capability over many years, improvement capability through the Q community and data science capability through things like the Association of Professional Healthcare Analysts and the NHSR community. We produce research, and those slightly cryptic graph lines are something we do each year, which is our annual tracker of attitudes towards health tech and data. This is a survey of 8,000 people. We think it's the largest survey in the world of attitudes to health tech and data. And this year's one will be out in 2 weeks' time, so do look out for that. But I thought actually a good way to start today, thinking about attitudes to AI, would be to ask you all a question. So now I'm going to ask if you could go to Slido, please. Slido.com, you might already be on it. If not, look for the hashtag NHS AI strategy. And we've got a question here for you that I'd like to get your view on. To what extent do you agree or disagree with the following? Using AI will save me time in my job. Agree, disagree, or on the fence? Let's just wait for a few more replies to come in. If you're following us online, please do take part. Okay, it looks to have stabilized there. So we've got 76% saying agree and 11 disagree. So real optimism there about the potential of AI. Now, I wanted to ask you that because in our large survey, which we conducted last month, we asked 1,300 NHS staff exactly the same question. What did they say? Well, there was likewise a similar degree of optimism, not quite as much as the audience here and online, but as you can see, nearly 2/3 of NHS staff saying they think AI will save them time in their job. So it gives us a kind of optimistic frame with which to start our discussion today. We're going to organise what is a very complex issue we're discussing into 3 different blocks. We're going to start by looking at what opportunities does AI offer for the healthcare workforce. We're then going to move on to look at some issues of regulation and trust. and finish by asking how the healthcare workforce can be supported to adapt to the rise of AI. So that rather optimistic first question perhaps leads us into thinking about the opportunities. And Avi, maybe I start with you. How do you think about the opportunities for AI in healthcare?
Sure, thanks, Tim. And afternoon, everyone. Really great to be here with you all, and thank you for the invitation. I think that first half, the first act was fantastic, and it's always hard when you're the second act to build on that, but we're going to try. And I guess before I just jump into opportunities, just to take a moment to reflect, actually, and I think this was brought up in the first half as well, around the journey we've been on with AI over the many years. If we think back, Nell mentioned that sort of Turing comment 75 years ago, and how AI has progressed from those initial sort of rule-based systems to then machine learning, deep learning, and then now where a lot of the hype is around foundation models and generative AI, which a lot are talking about as potentially an inflection point in AI and more broadly. And I think it's important to recognize, I think, this step change in capabilities, because it is part of what's opening up opportunities and new opportunities that weren't possible before in many industries, including healthcare, but of course across society more generally. And to then jump into where are the opportunities in healthcare, I think, I agreed with a lot of some of the comments in the first session, actually. And just to frame it in a similar way, so I've worked personally, as a doctor by background, in clinical applications of AI and clinical decision support, but also now in non-clinical applications of AI. And sometimes we like to frame it as sort of front office versus middle and back office. And I think I would definitely agree with some of the statements made earlier around, at least in the short term, we see a lot of opportunity in that middle and back office function, where we think about things that are relatively lower risk. You can achieve value much more quickly in that lower risk setting, and again, alleviate that administrative burden from staff that frees them up. But also, whilst in parallel, still focusing on the clinical applications that we know will take more time to test, evaluate, and build the necessary evidence for. And I think just to give you one example very quickly about some work we've done recently at IBM with the NHS, again, focusing on the sort of middle and back office, we focused on missed appointments in outpatients, and just through some user-centered research and application of AI techniques, we were able to show a 60% reduction in did not attends. And that's opening up an extra 700 appointments per week and potentially 36,000 appointments per year. So you can see the benefit of focusing in those areas. And the last comment I'll make before opening up is just around, so it's okay to have this broad category of middle back office administrative workloads, but that's really broad. How do you know where to focus? And I really agree with Nell's comment earlier around it has to be a user-centered approach. It can't be technology-led. I think some parts of the last 18 months, we've been almost too excited by the technology, and we've been trying to force-fit it and find applications of the technology as opposed to the other way around.
Thank you. Hatim, you were nodding vigorously when Avi was talking about the potential of middle and back office. Is that your perspective too, as a GP?
Yeah, first and foremost, it's just a pleasure to share the stage with these individuals, and thank you for the invitation from the Health Foundation and all of you for joining. There is no doubt in my mind that the biggest opportunity is taking away some of the tasks that we do as healthcare professionals that are not necessarily need to be done by us. I think these events are excellent because they allow us to zoom out and think about some of the wider issues that we're dealing with. But let me just zoom us in for a second. I was on the back of a taxi the other day, and when I'm on the back of a taxi, I like to talk to the driver because my dad was one for 25, 30 years. And he started to, for some reason, he figured out that I was a doctor. And he started to ask me about his diabetes, his cholesterol, so somehow I ended up doing a consultation in the back of a taxi. But as I left the taxi, he said, "Doctors are God to people like us." And my interpretation of that interaction is, what people want is access. What people want is experience. They want to have the opportunity to sit with a clinician, a healthcare professional, someone who has the knowledge to be able to steer them and spend time with them and move towards that personalized healthcare. And that human relationship is so critical to that. So when I'm sitting in my clinic room on a Friday, what is eating up my time? A lot of the time it's things like repeated prescriptions, looking at normal blood results, and other administration tasks like referrals, looking at letters, acting on other tasks. And if we start to go back to what's been said before, really think about what are the things that we can start to address with this technology. Do the scanning to understand what technology can address these problems, and marry that up, we'll have gone a long way to demonstrating what success we can drive forward with the use of AI and automation. And in our practice in North West London, we're part of a pilot that the integrated health and care system is running, looking at how we can use automation to take away some of the pressures like patient registrations or looking at blood results. And recently we did some work with the Health Foundation, actually, who kindly hosted us, to look at some of the evidence in this space at Health Innovation Kent Surrey Sussex across the practices that we've been working with, and Tim, you were there. And we saw some amazing things. The fact that actually through using AI in triage, you can actually work towards giving people, clinicians or GPs, more time with their patients. So one practice had implemented this and now found that they were able to move towards 15-minute appointments. Because what I'm trying to do in my 10 minutes is see my patient, call him in the first place, see my patient, document at the end of it. And it's just too much. And then I've got all the admin that comes alongside that.
Yeah.
We have to free up those pressures.
It's a really powerful point, and I remember that session well. I mean, just to come back to that, we've looked at the Health Foundation in our work about how technology, including AI, can free up time for staff. One really interesting question is how that might get used. So we did a survey recently. I promise you this is the last research slide I'll show you. But it shows you really the variety of calls on clinical staff's time, where spending extra time on direct patient care is clearly the top option, but there's lots of others as well in terms of management, admin, training, and so on. But it's really interesting when we talk to people who said, I would use my freed up time for patient care. It was clear that a large proportion of them were envisaging better quality consultations and higher quality care with their patients. So what you said really resonated there. Avi, you talked about the clinical and middle and back office split, but clinical is presumably still very important. Susie, let me come to you at this point, because you're using AI in your work as a radiologist, yeah?
Absolutely, and thank you for inviting me to this prestigious panel. I'd like to echo a lot of the things that have been said before about removing some of the very annoying things that happen in our day-to-day practice. And as a radiologist, a doctor specializing in medical imaging, I want to put into context how AI works for us. So there are hundreds and hundreds of AI regulatory approved products for healthcare, and would you believe 75% of them are related to radiology and medical imaging. So in my practice, we see a lot of things that are proposed to us for use. I'd like to take you on a patient journey so that you can see at what time points AI could touch that pathway and help us with our workforce. So you go and see your doctor, you might need an imaging scan. AI-enhanced clinical decision support can help us realize what's the right scan for you, where can you get that best, do you need to go to a specialist center, and also some of the back office stuff could tell you whether or not the nearest hospital or one that's a bit further away has a space for you sooner, so you're not waiting so many weeks for your diagnostic test. When you come into hospital and have that scan done, we already have AI that can be embedded into our scanning equipment that can improve the image quality, reduce radiation dose if you're getting a CT scan, and speed up scanning time now if you're having an MRI, which can be quite a long time. How does that impact our workforce? Well, our technicians who are taking the scans can finish on time. They won't have to work overtime. They might even have a lunch break. You as a patient might be just a lot more comfortable. You can have the scan done in a shorter space of time. You won't have to say, oh, I can't do this. I'll have to come back another time. Less likely to complain. Once you have the scan done, how does that impact care? Well, triage systems we've talked about. If there's something abnormal on the scan, that can be flagged up immediately to the frontline clinician. In some places, such as stroke care, we're seeing the stroke physician get involved very, very soon. But also as a radiologist, that scan, if it's abnormal, comes to the top of my reporting pile rather than waiting and seeing a lot of normals before we come to your very abnormal scan. As well, we know that AI-enhanced diagnostic testing and accuracy rates can be increased with some tools, especially for those less experienced. And we know it can improve quality and also confidence in scans. For example, in breast screening, we have 2 specialists looking at mammographies. Maybe an AI could be the 3rd pair of eyes, or perhaps it could replace one of the readers so that that person could be freed up to do other time. And we talked about annoying things in our job day to day. As a radiologist, some of the annoying things I see is having to go back and look at past imaging and trying to trawl through lots and lots of notes. AI can summarize all of that for me. It can also do automatic measurements, automatic volume calculations, so that I don't have to fiddle around with a ruler on the screen constantly. If I'm dictating a report, the AI can summarize that into subheadings for me, conclude what I'm saying so that I don't have to do that myself in a way that's probably more meaningful and easier to communicate to the referrer and to the patient. And in some cases, now looking a bit more speculatively, the AI can look at a tumor on the scan and maybe give me some information as to whether or not that's cancerous or benign and suggest potentially a treatment pathway, perhaps. But all of that combined, I think, just improves operational efficiency, saves time, gives us a bit more fulfillment in our work, and hopefully reduces that cognitive burden that we're constantly faced with, and maybe reduce burnout as well, so we can spend time doing other things.
Great. So, Erica, it almost seems like there's a plethora of opportunities. What now, not just your perspective as a radiologist, but from the vantage point in NHS England, what is seeming the most exciting to you at the moment?
So obviously this is a fabulously exciting bit of my portfolio, and it's really nice to be here with lots of other people who see this as a really exciting thing. We have some challenges centrally. There are thousands and thousands of potentially exciting AI algorithms and AI bits of kit for us to purchase. So there is a role from the centre working through the regulatory framework for that. That's a bit boring for some, quite exciting for others of us who see that as part of our role to keep things safe. Yeah. So I think we do have to work through what we need to do at the centre and what we don't need to do at the centre. And that is work that we've kick-started now and needs to be ongoing. I think for me, there's something really important about going back to what we talked about in the last session, having the patient at the heart of this. So we have been very reactive and not quite as strategic as we should have been. And others have said we've responded to market offerings rather than guiding the market as to where we have our challenges. And I think that's going to need to be the shift. And we heard that from Nels earlier, and that feels right now. We really mustn't be responding to those who shout loudest. We need to be having a conversation with patients, with our workforce, with our services to say, what are your biggest challenges? And I've kick-started that in the early autumn with all the national clinical directors and the other national medical directors to say, so if you had a wish list for what we could do tech-wise, what would be high on it for problems we could solve? We run horizon scanning centrally, and we're doing lots of work horizon scanning in this space. But I want to give you one little thought about the difference for patients. So I tested as a patient one of the voice-to-text tech bits of kit, and I'm a complex health patient. I go to lots of clinics myself. It's great to be a secret shopper. I've just been an acute hospital medical director, so my team's got very fed up of me popping up in clinics as a secret shopper. When I tested voice-to-text, the biggest difference that I would not have expected was that in every consultation I have as a patient, the clinician's eyes are down. And they're either writing, as they are in the Norfolk and Norwich, because we have paper notes still, oh dear, or they're typing. And they're not making face-to-face contact with you as a patient. And I initially found that quite overwhelming because I really wasn't used to it, even in a scenario-based conversation. I really wasn't used to it. And then I realised how utterly powerful that is and the emotional context of your consultation as a patient. And it has made me really reflect that our conversations about all this technology need to be on patient pathways and how we really use technology to innovate patient pathways and patient care. We know we can't carry on delivering healthcare the way we're delivering it now. We've seen the new government's aspirations, moving care into the community, digitising where we can, moving to prevention rather than a treatment-based healthcare economy. In order to do that, we have to innovate really successfully. And you can't change by simply running the hamsters in a hamster wheel faster. We've got to change what the hamsters do and what the wheel looks like. And I think a lot of this technology will enable that.
Thank you, Erica. Before you mentioned regulation, and we're about to move on to discuss it. Before we do that, I want to take the chance to put a couple of questions to the panel that we've had in specifically around opportunities that AI presents. Avi, perhaps I'll come to you in a second to answer this question. Will the opportunities for healthcare workers be greater than in other industries, and are there any other industries we can learn from? But perhaps, Susie, I could come to you first with this. Someone said, E. Kelly has said, we know AI exacerbates biases rather than mitigating them. How do we address this? And if I could just take the chance just to enlarge that a bit more, as well as biases from data, what are the other inequalities issues we're facing here with AI?
Thanks for raising that, and thank you to the guest, E. Kelly, for raising that as well. So I think, how do we address biases? I think the very first thing we have to do is just acknowledge they exist and talk about them and try to be transparent about them. If I could summarize ethics and AI into maybe one sentence, that's a big task. It's very much about learning who are the winners and who are the losers, and how do we all become winners in this is essentially what we want to do. So having that conversation, acknowledging it, is really important. When I go to a lot of AI events and they talk about bias, there's a lot of discussion about gender inequalities, race inequalities, socioeconomic inequalities. But one thing that I'm passionate about, and I hear a lot less being talked about, is age inequalities. Specifically, as someone who works at Great Ormond Street, I'm really fascinated about how children are affected by AI, because I don't think that enough is being done. If I give you another thing to put into context, there are about almost 800 FDA approved, that's regulatory approved products for healthcare, and less than 20 are actually approved for children. I think that's really shocking, and I also think that we could do better. In this day and age where AI and computer technologies are developing so quickly, whilst we want to be safe and protect children, I don't think leaving them behind is the safe and responsible thing to do either. So I think having that conversation is really vitally important.
Thanks, Susie. Really interesting to hear the age perspective. And Avi, what about other industries?
Yeah, no, I think it's a really great question. And one thing I always notice about other industries, particularly going back to the earlier comment about where to focus, is they often rush to focus in those areas where you can unlock value quickest. And just to give you one example, banking. We all have probably bank accounts here. I banked with NatWest. Maybe I shouldn't share that. I'll have to think about that. And just my journey on with mobile banking, I can do a lot with an AI-powered virtual assistant in terms of setting up standing orders, changing addresses, doing tasks, again, that can be handled safely, securely with an AI-powered virtual assistant. And that exists today, right? And you can see parallels between that and obviously improving patient experience and engagement in healthcare. And you asked the question around, will the impact be greater in healthcare compared to other industries with AI? And I believe it will be, because the challenges are greater. And if you can think about the step change that you can bring from, right now, a lot of us, we talked about our own experiences of being in the NHS, both as a patient or as a clinician. It can be really, really bad at times. We know that. And so the step change in terms of the improvement that can be made, I think can be quite significant. But to Erica's point, I know we're going to get to this in a second, it has to be done safely and responsibly.
Yeah. Well, let's get onto that now, because clearly, if NHS staff are to use and rely on AI tools, they've got to be confident in the framework we put around them, that they're safe and effective, they want to know what they're responsible for and what they're not responsible for, and so on and so forth. So that's why we put a slot in now to talk about regulation and trust. And Susie, let's start with you. Again, you're using AI. What matters for feeling comfortable with that?
Thanks. I just want to go back to something that was raised in the last panel that was so important, that is relevant to this, is you could have the best AI in the world that never makes a mistake, that does everything right, but at the end of the day, it's all about humans. And humans use technology, and if humans don't trust it, don't accept it, it really doesn't matter how good it is. It's not going to get used, it's not going to be implemented in care, and we're not going to get the benefits of it. So that's why I think it's hugely important we work with humans to adopt it, to trust it. How do we do that? Well, I have a great framework to think about the elements that go into that, and I'd like to say we need to keep it real. REAL, okay, which it's multifactorial, but R, first this harps back to something Nell said earlier. Relevance, is it solving a problem that we need it to solve first of all? R is also reliability, technical performance, is it performing as it should? E, ethics, we touched upon that earlier, evidence-based, clinical performance, and also e-explainability. If we think of AI as a black box and we're using it and it's giving us some direction, but we don't know how it came up with that, some way of explaining why it's doing that can really drive home some trust and help us adapt and use it a bit better. A is a big one that you just touched upon, accountability and agency. How do we know when it's malfunctioning? What can we do about it? What's the governance framework? Do we have post-market surveillance? Do we have a good quality management system? And do we have an agency to change it and improve the AI if we find it malfunctioning? None of us want to live in a digital world where computer says no and that's the end of it, and here's this invisible cage you've now created for yourself. That doesn't work for anyone, and that will make them not want to get on board with this. And finally, L is liability. So we don't necessarily know where we stand, and this was also talked about earlier on. If the AI gives you a direction, but you as a clinical doctor with all your expertise doesn't really believe that's true or great for this patient, and you go against it and you happen to be wrong, are you going to be punished more severely because the AI warned you and you ignored it than if you didn't have the AI? And that also might, make us less likely to adopt and use the AI. So for all these factors, it's really important.
Yeah, it's a huge list of issues, but very helpful. Hatim, of that list, what stands out for you?
I think when I'm trying to make a decision for the person that sits in front of me when I'm in clinic, I'm hugely reliant on the knowledge that's available to me, and it tends to come from clinical guidelines. And I have the confidence to know whether it's a local guideline or a guideline that's come from NICE, that has a vigorous process that's gone through, that guideline has gone through, and gives me that level of confidence to use it. So the critical word here is confidence. And how do we demonstrate with artificial intelligence, particularly at the pace that this technology is transforming, that confidence through the current regulatory pathways that we have in place? And then how do we translate that knowledge to the people on the ground that are using the technology? If we can solve that problem, I genuinely believe we will have moved towards a more responsible AI. And I commend this piece of work in terms of the strategy, because it is really critical. That responsible word is essential, because we need to protect people here. There is always a risk of the unknowns, and we have to be very, very careful. So post-market surveillance is really essential here. What role can we play as this technology changes, as clinicians on the ground, to start to feed back information effectively in real time?
Thanks, Hatim. Avi, from your perspective at IBM, does generative AI does that create specific issues?
Yes, it absolutely does. Firstly, a question for the audience of my own. Put your hands up really high if you get really excited by the term clinical risk management. Come on, Keith. Come on, Keith. There we go. 3. I'm visualizing 2,000 hands online, raised very high.
We could have done that on Slido.
We could have. But look, okay, second question then. Who thinks clinical safety, clinical risk management is absolutely fundamental to the success of AI adoption in healthcare? No surprises there. So look, clinical safety, clinical risk management has to be front and center in this process as well, because of the risks specifically now around the new technological advances we've seen in the last 18 months. And there are very specific new risks. And so when I'm thinking about risks to do with generative AI and foundation models specifically, I like to categorize it into 3 different buckets. So you've got traditional, which are sort of known risks associated with traditional AI systems. You can think of things like data privacy in that. You've got amplified risks, which are now intensified due to the advent of foundation models and generative AI capabilities. Think about bias. So now we're actually potentially could exacerbate the biases we already knew were at risk in that traditional bucket. And then really we need to keep an eye on is those new risks, those emerging risks that are inherent with foundation models and generative AI capabilities. And a great one is model hallucinations, right? And so all of us, I'm sure if we've experimented with tools online, we would have had one of those moments where we get something that's, incredibly confident, sounds like it's right, but is completely nonsensical and factually incorrect. And that is a hallucination. Others like to call it errors with confidence. Now, that's okay maybe if you're writing your GCSE essay. but it's not okay if you're delivering patient care. So you've got to look at the potential risk that something like hallucinations can have in a clinical setting. You know, a large language model making up a research paper to support a treatment regime, and many other examples. And so we've got to really think about the limitations. There is huge potential, I absolutely agree, but there are lots of limitations with these models as well, and sometimes that's not talked about enough. And just model hallucinations is just one example. One other thing to mention is around LLM specifically is they're non-deterministic in a way that you can't always control the output. So for the same input, you may get a different output. If any of you have tried that already, you can never get the same image twice, right? It'll always be slightly different. So think about that in a clinical setting. How does that work? So I'll pause there.
It sounds scary stuff. What do we do about it?
I mean, so one aspect firstly having this discussion so we're all aware of the opportunities but also the limitations, and that comes down to the whole education piece that we all need to be aware of when we're using these tools, what the limitations are so that we don't use them outside of those bounds. I think then responsibility lies at different levels on technology companies, on governments, on specific industry bodies to come together to develop those standards, industry specific, right, and regulations. I think it's really hard to regulate the technology as a whole. Say we're going to regulate generative AI. How do you do that? However, we can do it within the industry. And then also think about practical solutions. So one example, just something that we often talk about, is around a nutrition label for AI to promote transparency. So if we go to Sainsbury's or Tesco, I'm not going to show any bias here as to where I shop after making that mistake, but you know, when you go and buy your Weetabix and Shreddies in the morning, you know, you will see a nutrition label which tells you all the goodness or badness that's in it. We need the same for AI. So with a nutrition label for AI, for example, you know exactly how the model has been trained, by who, with which data, how it's been tested for bias, the governance that's in place. That's a very simple, practical example that you could use today, and it will really help those who are implementing technologies to understand both the benefits and then the limitations of that AI solution they're looking to purchase.
Great. Erica, what are the regulatory issues that you're seeing and thinking about at the centre?
So I'm particularly concerned about generative AI and it learning bad habits and then putting them into systems and processes. And I think we have to out that and have that conversation really openly and agree in healthcare economies that when we're implementing generative AI products, that part of our job is post-implementation surveillance, data collection, review, audit and performance management. I don't think we have a choice about that. Having said that, the power is huge. I have tested it. It can invent the most fabulous stuff that is utter rubbish. And it can be very convincing in the way language is structured. So it is quite frightening. In a much more basic way, I'm working through the is it a device or isn't it a device narrative. Which is
when
really
something's
challenging.
construed as a medical device.
Is it construed as a medical device that requires the MHRA to really go through it with a fine-tooth comb? Or can a company self-declare, that there is no requirement for regulation? And I'm particularly worried in the AI space where there are some products that make irrevocable changes to a digital footprint, whatever that may be, and lose the original data. For me, that is a device, and that requires regulation. So I'm doing some more work with MHRA. There was a comment earlier on about the number of people. We're going to need a lot of people to do this. And those teams are tiny. The team looking after AI that I work with in NHS England and the DHSC and the Digital Policy Unit is really tiny. So we are going to need to make some decisions about where we invest in order to get the most out of this technology. And I was talking to a chief exec of a big acute trust recently who had moved there not that long ago, who said that he'd inherited this brilliant EPR system, and it was like the Rolls-Royce of EPRs, but it was being implemented and was being driven like a 2CV. And I'm quite worried that we've got a bit of history of this. Lots of our EPR implementation has been to replace prior systems with digital. So we go from paper-based systems, you put digital in and it does just the same thing but does it digitally, and then you wonder why you haven't innovated and you haven't changed very much. Well, it's a no-brainer, isn't it? And I'm a bit worried with AI that, you put AI into an emergency department where it tells you whether a long bone's been fractured or not. All that does is take one tiny bit of a pathway out. It's not actually delivering the kind of change that Susie describes as how we could do it, where we put it for everything. And particularly at the moment, we're very focused on how we deliver reduced waiting times. The AI algorithms that can optimise weights and capacity and demand across organisations really do work, and they really do change geographical variation, so that patients a postcode away, who at the moment might wait 6 weeks for something versus 56 weeks, we can actually do something about that. So there are some AI things there that I think we need to get on with and really use.
Thank you, Erica. I've had one really interesting question come in. Probably more than any other industry, healthcare must focus on AI governance. Do we need tech to police tech, especially given the speed and scale of AI, which is an interesting thought. Any ideas from the panel on that?
It's an interesting question. As with any artificial intelligence at the moment, you still need a human in the loop. But can we augment human activity and the teams that you described that are really challenged through artificial intelligence? I have no doubt. And that might be a really good place to start. Because actually it's complicated and we have to get it right, but it's not directly patient-facing. Of course, downstream, it has an effect on patient care. But we should really start to think about what tools currently exist that will start to enable us to do that and support these teams that are working so incredibly hard to try and keep up to pace. Because there is no doubt in my mind that the question that keeps me up at night, how are we going to police this realistically when, as you say, there are technologies that are coming into place in practice that actually evolve over time, and suddenly we'll start to move into new use cases, and how are we going to keep up to date? Now, we do have incredible regulatory pathways. We need to ensure they're followed, and we need to enable them.
Avi?
I guess I have to comment, right? Being from a tech company, absolutely the technology industry more broadly, not just IBM, but everyone has a big responsibility here. And we know that at IBM, for example, and a lot of, I know we'll talk about in a second, around skills and training and education, but then what I talked about around being responsible with the transparency around the AI models that are being developed. That is absolutely critical so that others know the limitations when they're being implemented. But it's not the technology industry alone, right? It needs to come from government regulations, from other bodies as well, industry-specific bodies. So in our case, working with NICE, CQC, and others, and having that cross-public-private sector collaboration is essential. It's interesting, though, Hatem, your comment around a human in the loop. So just on my way here, I was reading an article from the Stanford Healthcare AI Consortium. They did a survey of 50 health leaders on exactly that question. And do you know what percentage thought a human should be in the loop of AI? Which is interesting, which surprised me. Guess what percentage of quote-unquote health leaders in the US?
70.
12%. Wow. Interesting, right? So the debate goes on, right? And I'm not saying I agree with that. I'm just stating it's quite interesting to see those types of discussions.
Really interesting. I'm going to jump us on to the final section of the discussion, looking at how the healthcare workforce can be supported to adapt. Clearly, for the NHS to take these opportunities, those who work in health and care services need to be ready to take advantage of them and indeed supported to adjust. Hatem, I'm going to come to you to kick us off. But just let me say, if you're listening either in here or online, please do send in more questions, particularly on this issue of workforce readiness, which we'll be coming to soon. Hatem.
So we heard earlier from Harris that we should be really proud of where we are as a country. And I think one area that we should really be proud is workforce readiness, because actually in 2018 we had a Topple review and we started to think about this question, and multiple recommendations came out of that. And for me, there's three elements to this. The first is literacy. What are the skills and capabilities that people need to be able to work with this technology effectively? And that's a core part of this piece of work that's been done by the Health Foundation. And there's two elements to that, really. One is general foundational literacy. What does everyone really need to know? Because we don't need to have significant expertise in every detail of how AI works. We need to understand actually what is useful information for the average person, be it in a clinical or non-clinical role on the front line. And then for those that want to take on more expertise, how do we create that space and opportunity to allow them to do that? And again, Harris and the team have done some wonderful work around the clinical AI fellowships. Giving clinicians the time, moving away from research and development, but actually giving them time to work on AI deployment activity on the ground, that is really valuable. How can we free up more time for people to spend their energy on this, particularly given the workforce constraints that we have? The second part is how we're going to work differently. Because and in the work we did in 2022 to look at how AI will impact the workforce, we found that a significant amount of these technologies are going to be in the diagnostic space, and we've heard about the impact on radiology. When I think about general practice, actually, how does it affect me, but also the team more widely, and that was quite high in terms of a workforce group affected. So we need to start to understand how will they change what they are doing, and what new things might they be doing, and therefore how do we train them differently. And that analysis really needs to be done soon, as far as I'm concerned. And then one final point, and again comes down to confidence, because confidence isn't just about regulation and liability, but it's also about the culture, the strategy that sits behind, and the implementation of how we implement this effectively in co-design and work with people. And it comes down to things like user design. Does this actually truly make my job easier, or is this going to make my job harder? Does it really fit in with my workflows, or does it fit outside of my workflows? And then understand the bias question. Does this create more bias and more inequity in what I'm doing? Or actually, can we narrow the gap through using this technology? How should I think about using this technology in my practice? That human-AI interaction piece, thinking about interpretability, thinking about explainability. We really need to start to analyze on the ground what that means. If something is sitting in your room, producing your notes, giving you advice about what you do next, what does that actually mean? And what are the biases that sit around that?
Yeah. Erica, did you want to follow on from that?
Yeah, and I think Hatim's described perfectly how we need to train our workforce of the future. I must admit, I worry a bit less about the workforce of the future because they're used to having AI in their pocket, and they're used to making judgments about what comes in their social media feed. They're used to that. I worry much more about our existing workforce and our older population. So making AI fit for purpose for my 85-year-old mum is not going to happen unless we really think about it. We get proxy access right, both for children and for those who've allowed their children to provide their care and support them. So I think there's something about all that narrative being embedded in the way we educate the clinicians of the future, but it's much harder to educate clinicians in practice. And actually changing people's practice and getting people on board who are already doing the job is going to be much more tricky. And I think part of our job nationally is working with regional teams, local teams, ICBs, providers, to say, what do you need and how can we help you deliver the changes you need with tech that we've looked at and we're happy with, or we don't need to look at because it's actually gone through enough evidence base to be okay. And then the workforce will engage, because the worry is that they will switch off otherwise.
Really interesting. Avi, can keep going along.
Yeah, sure. No, first I just want to say I completely agree with Erica. I was going to make that point around, I work with some clinicians, young clinicians who are fine-tuning models in their spare time and completely comfortable with prompt engineering, and you'd worry less, as Erica mentioned, about them. And I think one of the key points to mention is around this concept of what's often talked about is reskilling. I think that's different to upskilling, and we know roles will change. They may not be replaced, but they will change. And I think it's a challenge then how you get this reskilling agenda right. Just again, to give another stat, the average half-life of skills maybe 20 years ago was around 30 years. What do you think it is now, average?
5.
Yeah, close. 3, 5, 3 for some tech roles, actually. 5 to 7 years on average. I mean, that pace of change and reskilling, that is really hard to cope with. How do you set out the right agenda to do that? And also then, what does a career path look like? How do you create the career path? How do you create professional accreditation in these areas when you know people may be reskilling every 3, 5, 7 years? So I think that really needs to be thought about. And, you know, we're already behind in a way, if you think about it. So it's like, how do you catch up and then also put ahead the strategy for the future?
Thanks. Susie, what issues do you see looming?
Yeah, I'd like to follow on from what Avi said. So the way I look at it is every time you introduce a change into an ecosystem, you have the primary effects of that change directly related to that, let's say, AI, but also the secondary effects, the downstream effects that may not be directly related to the AI, but consequences of, which Avi mentioned. So first, speaking to the first point, I worry that when we have AI in practice and we've built on the trust, people trust it too much. And they start to rely on it quite heavily and stop using their own brains, their own skills, and they go through a period of de-skilling. So for example, if we use AI to report all our chest x-rays, maybe we get to a point where we de-skill and we don't really get the practice of reporting them. Our trainees don't get trained to do them very well. And when we're the human in the loop and being told to be vigilant, look out for mistakes, well, one, what if I'm worse than the AI and I can't find the mistakes? Or two, maybe I want to switch off a bit and I become complacent and just go along with what the AI says, so-called automation bias. And how do we counteract that? Do we do what they do in airport security and put in a fake bomb, like fake patient data, put in a cancer every now and again and see if we spot that? Do we switch off the AI every other week to force people to use their brains? I don't know how popular that is or if you can even do that. Or do we do something else clever? I don't know. Maybe instead of being AI literate, we now have to do a medical exam every year to make sure we're medical literate, perhaps, as well. And the secondary changes I've seen, I can give you an example, and that goes to role changes that you mentioned, but in workforce, is in one NHS trust, they implemented an AI tool that would flag up lung cancers on a chest x-ray as soon as the x-ray was taken with the patient in the actual department. The point of that was so that the technician who was getting the image could then tell the patient, right, there's something here, let's get you to a CT scanner so that we can do further investigations to make sure this isn't something bad. Now, that sounds great in practice. Before, the patient would have to go home, wait for a letter from the GP or a phone call, then come back in. But the reality is now that technician who was taking the scans has to have this awkward conversation, this communication, essentially breaking bad news in a way, dealing with patient anxieties, rebooking, trying to find the time to do that. And maybe that's a role change they never signed up to, they weren't happy with, they weren't trained to have. That has nothing to do with learning AI, but that is a consequence of having put the AI in place that we also really need to think about.
So it's those wider skills too.
Absolutely.
We've talked a lot about skills here, but Hatim, you mentioned the word culture. And I just want to ask you a bit more about this, because obviously you're working, I guess, at the coalface between the NHS and industry, and a lot of this will be the NHS working with industry. Is the culture right there? What needs to change?
So change is difficult, and culture is such a critical part of that. And if we think about what drives that culture, it's what Erica described in terms of the history. You know, what have we been through with EPR implementation and other digital changes that we've had in the NHS and those experiences? And the reality is those experiences at times have been difficult. So how do you change that culture? I mean, it's incredibly complex. I remember having actually this question at an interview once, and it was terrible. But when I actually asked the interviewer afterwards about what would have been a better answer, and the question was essentially, how do you drive that change? So who do you engage? What are you going to do about the person that says, no, I'm not doing that, I'm going to leave it alone? And I think one of the ways that you can address this is by finding those early adopters, finding the people that are willing to just be ahead of the curve, try something that they know might have a positive impact, and then working with them to collect evidence. Because we are an evidence-based industry. And then, with that evidence, you can do things like change commissioning and change incentives. You can actually get to the clinician on the ground and say, look, this actually works, right? I've demonstrated this in this study over here or through this evaluation over here. You can talk to the financial officer and say, we've got an economic evaluation here. We know that actually this is financially sustainable and going to save you money in the short term, ideally, but definitely in the long term. So it's really trying to unlock what are the key things going to help people help to get people on board in their different roles.
Yep. I mean, we had a question in asking about what is the role of a health innovation network in this agenda. Do you find yourselves more and more playing a part in that kind of brokering at the coalface and culture change?
Yeah, absolutely. Look, it's a very privileged position to be able to spend time with people across different industries and spend time with people like Avi and really understand what's going on and have that headspace to do that. And it's a very privileged position to also spend time with NHS leaders and NHS providers on the ground to really understand what their issues are and then start to bring all of that together. I don't know if many of you have seen that penny farthing graph or infographic that shows the amount of investment that goes into research and development and the amount of investment that goes into implementation science and embedding change into practice. The reality is there's a big disconnect there, and that we need to find a way to enable implementation to be able to get the right things into practice quicker. And we heard it earlier.
Thank you, Hatim. We've had a question from Matthew Drewitz. AI will likely excel at personalised care. How will the role of humanised care change? And how does the panel think this change will manifest? So I suppose that's personalisation in the sense of tailoring and sensitivity to personal data. But what will it mean for that human dimension of care?
I guess I can answer that to start off with. It really depends on the healthcare system that's being implemented in. So in a place where you don't have enough workforce, you don't have enough people to see the patient, then perhaps that humanized care will disappear and it will all be driven by the AI. However, if we're in a place where we are supported by a medical workforce, maybe backed by complex, expensive insurance, who knows, that will pay for that, we may see a premium for human-centered care where you see a person who can empathize with you as well as with that AI embedded. So I think we might see a different tier of type of healthcare emerging if we use AI, one to drive quick, easy, fast, generation of patients through the system, but one that might be higher quality if we don't do anything about our workforce, and that's a premium for us. So that could be one way.
Avi, what about you working in tech industry? How does industry see itself in that way as against that kind of more human relational side of care?
I definitely can't represent industry here, the whole of industry.
Well,
but I'll take it from my personal perspective. I think, I agree with those comments. And look, it's an interesting comment I see often coming up around what does this mean to be human, sort of like the advances in AI and this sort of philosophical question around where the boundary is. And look, we have choices to make. And we need to recognize that at this stage in the journey, the choices we make now are going to impact whatever happens in 10 or 15 years. And I think the good thing, though, in a healthcare perspective, as we talked about, is what this may allow healthcare staff and professionals to do is really go back to the emotional connection and the human connection, which we all feel has been lacking because of real reasons, because there's no time, there's too much pressure. And I think that's one of the big benefits that AI can provide, is not for the AI to try to be human. Let it excel in summarization and prediction and all that good stuff. Let the humans be human.
Great. Erica, let me come to you last of all. Not only for your thoughts on that, give us some wisdom to round off the session.
I was just thinking about a product that I was looking at, which was avatar-enabled consultations. And I think we have to really think about what we mean by human interaction and what we mean by humanized care. Now, I think quite a lot of the AI that we can use in terms of so-called back office or process automation frees up time to care. And I gave the example earlier of not having to type, not having to write. That's just amazing. But I do think when you start to look at some of the really front-end products that are emerging, and the avatars for mental health support and cognitive behavioural therapy, the evidence is people love them. They love an avatar. Now, where does that leave us with you really need to see a real clinician? And how real does that avatar feel if it's programmed to be very responsive? And, the app that I use for online banking, she's not very responsive. She winds me up a lot. Might be the same as yours. And I think we have to get all of those things right. But I do think we're shifting hugely from a traditional model of care. And I had to brief some ministers 7, 8 years ago who were hell-bent on AI removing radiologists. We won't need you anymore, Erica. So I'm face-to-face with the ministers, advisors. We're not going to need you. And I went back into my next clinic, and I only do the hands-on, face-to-face bits of breast and gynae imaging myself. So where's the AI going to do the biopsy of the tricky little thing in somebody's armpit, sitting between a nerve and a big vessel? And where's the AI in terms of doing a transvaginal ultrasound scan? You know, there are bits of health that absolutely need us. But when I, as medical director, I was running a robotics surgical program and supporting surgeons in doing that. That requires the surgeon, but it then requires the robotics, and it then requires a whole load of algorithms. And if you make that seamless and you put your algorithms in to get the right patient into the theatre with the right kit and the right staff, and you use it to optimise your waiting lists, then you're using AI in a different way. And I think that's where we need to have those intelligent conversations.
Yeah. Really interesting. What you were saying about the avatar reminded me of a comment we heard from the minister earlier, who talked about the need to fundamentally change how we imagine and deliver healthcare. And it's really interesting, isn't it, while being sensitive to all the differences and preferences, different preferences that exist, some of the opportunities that this is presenting to do things in fundamentally different ways. To draw this session to a close, I wanted to ask everyone to go back onto Slido one more time, where we've asked the question that we've posed in the title of this session, opportunity or threat. Will AI be an opportunity for to improve jobs in healthcare, or are the pessimists right in seeing it as a threat? So could I ask you to go to slido.com, look out for the hashtag if you're not already in there, and vote on that. It's just a very crude temperature test, but we'd like to know, having listened to the session today, where do you come down on that question? Wow, so 114, and we have 92% saying it's an opportunity, so that's really glass half full. Now, here's a time where I can't show you what our NHS staff have said to this, because we'll be publishing this in our tracker survey coming out in 2 weeks. So look out for that. To give you a spoiler alert, it's a more balanced view than we've got from the audience today.
Audience bias.
Yeah. Well, I won't say any more, but we will be delighted to share that survey when it's out in 2 weeks, so please watch this space. Thank you so much for taking part in this session. Thank you to everyone who submitted questions, both in the hall and online. Most of all, thank you to our panellists for sharing their expertise with us, Susie, Avi, Erica, and Hatim.